Hello everyone, I'm Anita Wallace, I'm Chair of the Lymphedema Support Network, and I'm delighted to introduce you to Professor Dominic Furniss, a microsurgeon with a special interest in lymphedema. Another form of surgery in lymphedema is lymph node transfer. Can you tell us some more about that and who is suitable?
Yeah, so lymph node transfer is quite an invasive technique to use for patients with lymphedema. So compared to LVA, which is the other main reconstructive option, this is much more involved. It's a longer operation, requires usually 2-3 nights in hospitals, done under general anesthetic, whereas LVA, is day case surgery, relatively minimally invasive. The potential complications are also a little bit more serious because of the nature of the operation. This means that as a general rule, we will offer lymph node transfer much less frequently than we offer LVA. This technique really is useful for people whose lymphatics are not quite good enough for LVA, but they're not quite at the stage where they've gone beyond reconstructive options. That's certainly where we at the Oxford Lymphedema practice see this fitting in. And so a patient may have a lot of fluid rather than a lot of fat. But when we do their ICG scan, we don't see that the dye moves quite as far as we would like to see it move in order to offer the patient LVA. So it's a sort of in-between place, really, in between people who we catch relatively early in the disease and people who come to us very late with the non-fitting edema. How does it work? Well, what we do is we transfer a bunch of lymph nodes plus their associated lymphatic channels from one part of the body to the affected part. So for example, let's say someone is affected by lymphedema in their leg. We might transfer some lymph glands from their neck or from inside their tummy. And some surgeons will choose lymph glands from the armpit as well. We've decided not to do that because many of our patients are fearful of getting lymphedema in their arm if they've already got it in their leg. The published rates of that are quite low, but most of our patients don't want to take any risk with regards to that. So we tend to choose the neck or inside the tummy. And we would find, so we take the lymph glands with the blood vessels that keep them alive, and we would transplant them down to the leg, to the affected area, and replumb the artery and the vein in order to keep them alive again. We make a little pocket in that subcutaneous tissue to fit them in, and then we wait. And I think the most important thing to say about lymph node transfer is it doesn't seem to have an effect straight away. You have to be really patient to see some results. And many of our patients don't see any kind of change for up to a year, really. And I think what's happening is those little lymph channels are joining up with the lymph channels in the affected area, and the drainage pattern is changing over that time as the sort of scarring and lymphangiogenesis really takes hold. And we have seen some good results with lymph node transfer. We've seen some patients who it hasn't really made any difference to at all. So yeah, I think in our practice it has a bit of a niche role. But there are other surgeons who will do more lymph node transfer than us, and they say that they see very good results with it as well. So I think it's important that patients talk to people. They go and have consultations, and they think about what's the right route for them to go down.
Thank you, Dominic. Thank you.